So, Dr. Srikumar, can we start now?
Yes, Dr. Sahu, sure. I will just start sharing the presentation.
So, good evening, everybody. A warm welcome to all the participants for this webinar. Basically, this webinar is meant for the young physiatrists and postgraduate students. And we are really lucky that our senior faculties, senior professors are also joining to give their comments, give their compliments to this webinar. Today, we are privileged that we have with us our Professor Yusing sir. And sir, thank you very much for joining with us. And without wasting much time, I think we should go ahead with this. We'll expect a very good clinical discussion today from Dr. Srikumar. He is the additional professor and physiatrist at AIIMS, New Delhi. He was also our treasurer for a long period for our association. He has a vast experience in this field of spinal cord injury, and his clinical interest is in spinal cord injury. So really we'll get some beautiful ideas regarding this management of spinal cord injury, especially localization of neurological level as well as prognostication of spinal cord injury. As you all know, spinal cord injury is a devastating condition, difficult to manage the medical pathology, especially despite of tremendous prognosis in neuroscience and neurosurgery management. Due to increase of high velocity vehicles, more and more young people are affected with this. And at one point of time, the life of an individual with spinal cord injury completely changed. So the immediate treatments are directed towards rehabilitation, resuscitation under spinal stabilization, but there is no definite treatment for trauma to the spinal cord injury itself till date. Hardly any focus is drawn on the acute stage management of spinal cord injury except the resuscitation procedures. But still, researchers are on to see, to know the prognostify the outcomes of spinal cord injury, especially this nowadays the research are more going on the estimation of biomarkers in the cerebrospinal fluid. As you all know, this injury to the spinal cord releases some of the neurotransmitters which can enter to the CSS space because of injury to the spinal cord. Nowadays, some markers like certain neurotransmitters, phospholipids, glial fibrillation, acidic protein, neurofibrin, interleukin, tumor necrosis factor. These certain factors are now can be estimated from the CSF to prognostify the conditions, the outcomes of the spinal cord injury. However, in this topic, Dr. Srikumar will elaborate regarding how to localize the neurological level of injury and the different prognostication factors in spinal cord injury. So hope this webinar will be certainly helpful for everybody starting from postgraduate students to all young physiatrists. Thank you. Over to Dr. Srikumar, please.
Thank you, Dr. Sahu. Thank the organizers, the Department of PMR, SVNIRTAR, IAPMR, and also the Association of PMR of India for inviting me.
Can you be louder, please? I think your voice is a little bit low.
So thank you for the invite. And now jumping on to the topic, this is about the localizing the neurological level of injury and how to do the prognostication, basically by using what is known as the international standards for neurological classification of spinal cord injury. So how to use this standardized assessment and how to classify the spinal cord injury patients, the traumatic spinal cord injury patients especially, using based on this assessment, we classify them as per the motor level, the sensory level, then the neurological level of injury. Then we look at the impairment scales, and also we try to find out what are the zone of partial preservation, because these have an implication on prognosis. Again, when we come to prognosis, we'll shortly see, briefly see how this international standards again is useful for prognostication, and what are the factors or the determinants of prognostication, and what are the key prognostic indicators within the international standards of neurological classification as per the level of injury or the completeness of injury, etc. So this is, I think, all the residents being posted in PMR is first introduced starting from the year 1. And this is the worksheet of the international standards for neurological classification of spinal cord injury. And this all started in 1982 when the first standard was established by the American Spinal Injury Association. And now we have with us, since 2019, the 8th edition. So over the years, it has evolved and it continues to evolve. Again, this is not the perfect scenario as such that we have. There are some lacunae in it, as we will briefly also try to cover. And therefore, that such improvisations and improvements keep happening with time so that we are able to better have an accurate assessment and also an accurate prognostication as much as possible. So what is this international standards? It is an assessment. So it is a neurological assessment. It is not a comprehensive neurological assessment. That is because only the key points that are required for the neurological classification, like the sensory level, motor level, etc., are used. Whereas there are optional assessments which can be done, which are not part of the international standards. For example, proprioception and whether there is movement of the diaphragm is present or absent, and whether deep pressure can be perceived to the patient, those are optionals. And again, adjuncts of these international standards also I will not be touching upon. The adjuncts being, there is an international standards for autonomic function of spinal cord injury, which is an adjunct to the international standards of neurological classification of spinal cord injury. So here we will look at what are the basic standards, the assessment standards, and how to do the basic assessment and how to classify the spinal cord injury using that assessment. And why this is required? This is required because it enables us to set goals. For example, if you know the level of injury, you know what is the expected level of function. And accordingly, you can use your resources because the resources you know are limited. The number of physiatrists are limited. The number of healthcare resources are limited. The time is limited. So you have to use the limited resources to give the appropriate management to the patients. And for that, we must have goal setting so that we do not waste resources unnecessarily. And the second important outcome of this neurological classification is the ability to prognosticate. The prognostication is useful only when we have the data, especially of the acute spinal cord injury, not otherwise. If you do the neurological classification 3 months or 6 months down the line, and then you have a baseline assessment, you cannot use it to prognosticate how much it will improve. But if you have the data of the first 1 month period, how the classification was during the first 1 month, within the 1 month of spinal cord injury, then that can help us to prognosticate how the person will improve, how much the person will improve at the end of 1 year. So that's how it is helpful in prognostication. And usually, at what time should this assessment can be done? The assessment is usually avoided in the early stages within the first 4 hours or within the first few hours. And this is because the person is received in the trauma, he is in so much of pain. There is so much of resuscitation procedures which are more required rather than a complete assessment, which is also a tedious process, which involves patient cooperation because he has to respond to your instructions. And also there may be some medications which can disorient the patients. So all these things have to be factored and considered so that you have a reliable data when you do the neurological classification. So usually it is done between 72 hours to 1 day, but most of the data that are available historically or that is used to prognosticate are actually based on the data that are 1 month old, because it usually takes that much time for the spinal cord injury patient to be stabilized and to be seen by the rehab team. And then they use the for prognostication, and therefore we are seeing more and more evolution of this data as more and more acute parameters, that is data from the acute spinal cord injury within 70 hours or within the first 1 week, as they become more and more available, we will have better ability to predict the patients. Again, in the first few hours, we avoid taking this data because of several reasons, including edema propagation, etc. This classification is valid, reliable, and responsive, and it has also been validated not only in traumatic spinal cord injuries but also in non-traumatic spinal cord injuries. But the problem is using it in non-traumatic, not the problem, but the lack of the second outcome, that is the prognostication, will not have any value, because in non-traumatic spinal cord injury, there are different causes, and each of those causes will behave differently. And definitely, as it is evident, we cannot use it to therefore prognosticate. But it can be used to assess, and thereby can be used to have goal setting and prepare a impact plan. But it is not quite easy. Even though everything is in black and white, it has been seen that 75% of this worksheet carry at least one error. And most of this error occurs in the motor scores, and also whether the person is complete or incomplete injury. Again, there are so much of mistakes that happen there, and less commonly in the motor and the sensory error. And it has been seen that training can reduce the error. And therefore, I thank the organizers for bringing this up to initiate the process of training the young residents in this international standards. And for further training, you can go to the American Spinal Injury Association website, wherein they have this three-step module, which you can register and take it up and do the training on a complete basis. There are also some online algorithms that are used, but you should not be totally dependent on them, because they do not eliminate the errors. They can reduce the errors, but they cannot eliminate them. And always, it is your experience and it is your clinical judgment that plays a very crucial role in completing the worksheet properly. So in this algorithm, this is a computer algorithm. All you have to do is fill the gray boxes. Then the next step, that is a classification, wherein you have to do the analysis. That is done automatically by the algorithm. But however, you have to cross-check for any mistakes so that those can be eliminated. So now let us move on to the basics of assessment. These are basically sensory examination and motor examination. The only non-optional, the key examination that I'll be touching upon. And then we have the rectal examination. Even though I have written it separately, it is basically to assess the sensory and motor function of the S4, 5, S2, 3, 4, 5 segments. So again, it is part of the sensory of the motor examination. So the sensory examination, motor examination, so we do assessment of only two modalities, not the rest of the sensory modalities. Again, the rest of the sensory modalities are part of the non-optional assessment and are part of the comprehensive neurological examination. They need to be done in the ward on a day-to-day basis, on a regular basis. But for the purpose of the international standards, that is not required. So what are these two modalities? One is the touch, where we use a wisp of cotton or a cotton applicator, and then it tests the viability of the posterior column. And then we use a pin or a safety pin with a short end and a blunt end, which is used to assess the viability of the spinothalamic tract. So basically, the sensory examination tests these two tracts, the viability of these two tracts, and says whether they are still functional, whether they have escaped the injury, whether they are impaired with the injury, or whether they have been totally lost their function due to the injury. So what are the key sensory points? So you do not test from head to toe all the parts. It's not possible. So based upon the anatomical data, the several reviews, the American Spinal Injury Association has come up with key sensory points. It is these key sensory points that you need to memorize and you need to test in each and every patient. And you test them from rostrally to cordially, and you compare them with the normal sensation of the face. And you test them, for example, C2 is tested 3 centimeters behind the ear, C3 in the supraclavicular fossa, the mid-clavicular line, C4 the acromiclavicular joint, and C5 is at the antecubital fossa, C6, 7, and 8 of the proximal phalanx, of the dorsal aspect of the proximal phalanx of the thumb, the middle finger, and the little finger, respectively, and so on. So all these key points have to be remembered. And again, most of the thoracic and the abdominal key points are all along the mid-clavicular line. and that needs to be remembered. The T6 is at the line of the ZT sternum. The T3, 4, and 5 are at the respective intercostal spaces along the mid-clavicular line. And after the T6, we pinpoint the T7 and T10 at the level of the umbilicus in the mid-clavicular line. And at 1/4 distance between the T6 and the T10 is the T7, and at half of the distance is the T8, and at 3/4 the distance is the T9. Then we locate the midpoint of the inguinal line, inguinal ligament at the midclavicular line. We pinpoint, we test the T12, and the midpoint between the T10 and the T12 is the T11. The L3 is again on the medial malleolus above the knee. It's medial aspect of the knee, just above the knee joint. And the L2 is the midpoint between the T12 and the L3. Whereas L1 is the midpoint between T12 and the L2. So the L4, again, we look at the medial malleolus. L5, it is the metatarsophalangeal joint and the dorsal aspect of the third phalanx. And S1, the lateral aspect of the calcaneus. The S2 is the central aspect of the popliteal fossa. S3 at the ischial tuberosity, and S4 and 5 are just within 1 centimeter from the ano-mucocutaneous junction of the canal. So these key points are tested both for the light touch and for the pinprick, and they are stored as 0, 1, and 2. Sometimes when you have confusion, do multiple assessments, and when you have ambiguous answers from the patient, it is better to repeat the assessment at least 10 times. And the consistent result is considered, the result is considered as consistent if it is positive, or if it is the same on at least 8 occasions out of the 10 tests that you have done. So again, it is scored as 0, 1, and 2. 2 being normal and 0 being absent, and 1 is either altered or whether it is decreased or impaired sensation. That is, when the person you are touching with the flick of cotton, and you can move the cotton just within a 1 centimeter area of the key point. And if you can perceive the sensation, for example, at the level of D12, if you can perceive the sensation as good as the case, then that is normal. And again, for pinprick, you should be able to perceive the difference between the sharpened and the blunted. If it is not able to perceive, it is to be noted as absent. And all other sensations are to be considered as impaired. And again, in some cases, it may be not testable. That is, for example, if a cast is applied, if the person has another problem, for example, a cervical injury patient having an amputation, you are not able to assess that particular aspect of the hand that, let's say the C6, C7, and C8, you are not able to test. Then you put it as not testable. And you can see here that we have also introduced in this 8th edition the asterisks. In the previous edition, that is in the 2015-17 edition, the asterisk was used in the normal one. 2 star was used. But now 2 star is no more used. We have to assess as 0, 1, or NP. And asterisk is used whenever a non-spinal cord injury condition is present. For example, it could be neuropathy or amputation or any other non-spinal cord injury condition which can result in impairment. For example, the patient may have a neuropathy added on to spinal cord injury, a prior neuropathy. So then it will be 1 and it will be 1 star. If he has an amputation, then it will be NT, that is not testable, and you mark it as asterisk. And then in the worksheet, in the comment box, you have to write what this non-spinal cord injury condition is. And you have to mention additionally for the purpose of classification. This is the first step, that is assessment. And then we go to classification, that is we find the neurological level of injury. So this asterisk, apart from mentioning the non-spinal cord injury condition, you should also specify whether this for the purpose of classification, this particular level, whether it is to be considered as normal or abnormal. I'll give you an example so that it will help us clarify the situation much better. So totally, there will be some, we will then go directly to the example. So this is, for example, a case of spinal cord injury, and this person has a right forearm amputation. So we have, they have tested him, and it has been found normal. The light touch and pinprick are recorded for the right and the left side. So we see for the C2 for the both the light touch on the right side, both the light touch and pinprick, it is 2 and 3, and the C3 level is also 2 and 3, so on and so forth. But since this person has forearm amputation, that is the transradial amputation, you are able to test the C5 and the T1, that is at the antecubital fossa, but you are not able to test the C6, 7, and 8. The sensory function is C6, 7, and 8. We are not able to test because this is the, as I mentioned before, the proximal phalanx. So there is no phalanx, there is amputation, you are not able to test. So you record it as NP. But added to that, you put a star there. And you mention in this comment box that this condition is because of a right forearm amputation. And the asterisk says that for the purpose of classification, I will consider this person as normal for the particular level. Why? Because I use the clinical judgment. As simple as that, the level below is normal. So the level below being normal till T6, I can use this as, even though I'm not able to test it, I can put it as being normal. But what happens to the total score? You can see at the bottom here, you know that there are 28 dermatomes, and therefore the maximum possible score is 56. So once you have put NP, you will not sum up the score here anymore. You will only put it as non-determinable. And the non-determinable is used for both the light touch and the pinprick on the right side, but not for the left side, because here you are able to test it. For example, if this has been a case, unlike amputation, for example, a neuropathy, let's say he had only an impaired function. So then this will be 1, and you will mention it as star, and mention the star, and that because of the neuropathy, this is normal. But for the purpose of addition, you will include the score of 1, even though it is because of the impaired due to non-spinal cord injury condition. But for the summing up, where it is due to neuropathy and you have impaired is recorded, you will sum it up as an actual score instead of using the ND. So ND is used whenever NT, that is non-testable, is used. You use the word non-determinable in the sum box. Now, going on to the next assessment, that is the motor examination. Again, the motor examination, there are some key muscles that ought to be tested. And I will not go into the details because the best details are available, as I mentioned in this reference below. The motor exam guide, that is has been clearly specified by the American Spinal Injury Association, lists out very clearly the positioning of the patient. All these patients ought to be tested in the supine position, in the lying down position, and because you are seeing the patient the acute spinal cord injury, and hence a follow-up also you will use the same level, that is the same positioning, and usually the C3 is tested first. The MRC grading of level 3 is tested first for non-key muscle C5, and if it is more than 3, then you test for for the power 4 and 5, and if it is less than 3, you directly need to quantify whether it is 0, 1, or 2. So for C5, you test the biceps, and remember, the biceps is not just supplied by only the C5 segment. There are 2 segments, usually C5 and C6, but it is the most roster segment, C5, which has been identified for the purpose of classification. This is not the only innervation segment. So for the purpose of C5, the key muscle is biceps. Again, C6, we have the wrist extensors. For C7, we have the elbow extensors. C8, the distal interphalangeal joint flexors, which is being tested in the middle finger. And for T1, the little thumb abduction is tested. And again, for the lower legs, again, it has to be tested in the lying down position. And the only precaution that we have to follow is not to allow flexion to proceed beyond 90 degrees, because beyond 90 degrees of hip flexion, the pelvis will rotation has completely occurred, and further movement will occur at the lumbar spine. And if this person has sustained a lumbar fracture, that can cause instability, can cause worsening of the spinal cord injury, and therefore proper precautions have to be followed, especially when you are examining the patient in the acute setup. So L2, again, you test the hip flexors. For L3, the knee extensors, the key muscle, and L4, the ankle dorsiflexors, the L5, that is the great toe dorsiflexion or the extension, and S1, again, the S1 we know normally in the plantar flexors are tested in a standing position. But in spinal cord injury patient, the S1, the ankle plantar flexors are tested in a lying down. So the key muscles are again recorded based upon the MRC grading. The MRC grading is the basic. There is no difference between the MRC grading that is used in the spinal cord injury for the international standards. It is all 0, 1, 2, 3, 4, and 5. Again, it is important to note the star and not testable versions. So what is the purpose of star and the not testable? It is the same as that we used in the sensory exam. We have to specify whether the aspects, the impairment, if any impairment or reduction has occurred because of the non-spinal cord injury condition, that has to be specified. And again, looking at this same example of the spinal cord injury patient, so we know that this person had the transradial amputation. So you are not able to test the muscles of the hand and also of the wrist extensors, the finger flexors, and the little finger abductor, that is C6, C8, and T1, you are not able to test. But we are able to test the elbow flexors and the elbow extensors on the right side. On the left side, everything is tested and everything is fine. But again, we have specified that the person was non-testable because of the amputation, and we have put an asterisk mentioning that for the purpose of classification, we will assume that this level is normal as per the motor function is concerned. Why? Because subsequent levels we have normal dermatomal, and as I'll be specifying later, these can be used, the dermatome can be used for the motor level also. So going on to the next aspect of examination, that is the rectal examination. There are only two aspects that we measure. That is the deep anal pressure and the voluntary anal contraction. And in this, there is no numerical score that are used. We only record the response as being present or absent by registering the response as yes or no. Deep anal pressure and the voluntary anal contraction. And in this example, we see at the bottom that the voluntary anal contraction is recorded as absent, that is no, and the deep anal pressure is also recorded as absent, that is no, in this example. So we have finished till now the key aspects of the assessment, that is the sensory examination and the motor examination. The worksheet has been completed till the scoring has been done. So what next? The next is the analytical aspect of the assessment. But using the assessment, how do we classify the spinal cord injury as per the international standards? And even though it may look confusing, if we go step by step in the process and use the rules, if you follow the rules and nuances, then it is very simple. There may be confusion, but it can be simplified by doing it step by step assessment of the classification. So first step is to determine the sensory level for the right side and the left side. And the second step is to determine the motor level for the right side and the left side. And then we determine what is the neurological level of injury. And next step to that is we determine whether the injury is complete or incomplete. We will go into the details in the subsequent slides. And also, as the last step, we see what is the Asia impairment scale. That is, we grade them as per scale A to E. So we use this, how to grade it. So till the previous edition, this is all the steps that we had to follow. Following the latest 8th edition, we also added a step of zone of partial preservation, because initially it was used only in complete injury, but now it has been included also in incomplete injury. And therefore, the ZPP or the zone of partial preservation has been added as a separate step when it comes to determining the classification as per the international standards. So the sensory level, the simple definition, it is the most caudal. Caudal, that is the opposite of rostral. So it is the most caudal intact dermatome. Intact means it must be numerically, you must have graded it as 2. And it has to be graded as 2 for both pinprick and light touch, and it may vary for the right side and the left side. The sensory level may vary between the right and the left. So in this example, let us take the same example, cervical spinal cord injury patient with the right forearm amputation. We have graded him as 2 till T6, or is it till T2? Till C5, we have the rating of 2 on the right side, but in between, the recording is not testable. And now you will be able to understand why we mentioned the asterisks and we wrote that for the purpose of classification, this region is to be considered as normal. And by using this command, you are now able to arrive at the level as T6. Else you will be using it as C5. But that is not so, because it is very clearly evident that this is a case of amputation, so there is no doubt about it. But there may be some areas wherein some doubts may arise, and that is where your clinical judgment will be very useful. So the same goes for motor level, and for motor level, we will go next how to determine the motor level. It is the lowest key muscle function that has a grade of at least 3. That is 3, that is some functional power that must be present in the most lowest key muscle. It is only the key muscle that we are concerned with, not the non-key muscles, not any other muscle. Providing that the key muscle functions represented by segments above are judged to be intact. Previously, this was written as segment above have to be 5, but now it is now changed as you have to judge whether it is intact, because it may be 5 or sometimes it may not be 5, but you will assume it as 5. And again, for non-key muscles, what about non-key muscles? Wherever where we have to find a level, we have key muscles only for C5 till T1, and in between T2 till L1, we do not have a non-key muscle. So in such cases, myotomes without key muscles, in such situations, that is above C5, between T2 and L1, and between S2 and S5, we follow the dermatome grading. That is, if the dermatome is normal, we assume that the myotome or the muscle function is also normal. So for determining the motor level, if the testable motor function above is normal, we can use the dermatome grading, and we can also use the dermatome grading for designating the motor zone of partial preservation. Not just the motor level, but also for the ZTP, you can use the dermatome grading. So looking at this example, so here we have the C5, we have it on the right side again, you're not focusing on the left side. On the right side is the forearm amputation. C5 is intact, then we are not able to test at C6. C7 is intact at 5. Again, we're not able to test NP and NP. Then we have some dermatomes. We do not have any non-key muscle. The next key muscle is at L2, and that is it. So you have the range between T2 to L1, where there is no key muscle defined. So can we use the dermatome? Yes, we can use the dermatome to determine the myotome level or the motor level. If the dermatome is normal till 2, again, we will consider that this is the level. But at the same time, you see, we have not just mentioned it as T6, we have tagged it with asterisks. The asterisk is used again, assuming in places where this muscle function was non-testable, we have made the assumption that the motor function is normal. So now, after the classification of the sensory level and the motor level, the next is the neurological level of injury. The neurological level of injury is the most caudal segment of the cord with intact sensation and anti-gravity. There is 3 or more muscle function strength, and it is a single level. For sensory and motor, it may be different for the right and the left. Here, it is a single level, wherein both the dermatome and the myotome or satisfying this definition with intact sensation and some anti-gravity muscle function strength. Again, you're not using the word key muscle function strength here. You're using the word that muscle function strength because in the places where key muscles are not available, we can use the dermatomes. You're not talking about the non-key muscles here at all. You're talking only about the dermatomes, using the dermatomes and the key muscles for the motor level. So that will help us. The most rostral normal caudal segment will be created as the neurological level of injury. So in this case, there is again absolutely no confusion at all. A single segment for both the right and the left, it is T6, and the T6 is recorded again as the neurological level of injury, at which the dermatome is also normal and the myotome is also considered as normal. But again, the asterisk is further carried forward because if we had not used this comments, we would have not arrived at the level of T6, and therefore here also we carry the usage of asterisks. T6 star will be the neurological level of injury in this example. The next is to determine whether the complete or incomplete. This is by far the most important aspect of the assessment. And for the completeness or the incompleteness of injury depends upon the presence or absence of the sacral segment, that is the S4 segment functioning. And this function can be tested in various ways. One is the sensory function at the S3 and the S4 level. The other is the voluntary anal contraction, which we did in the rectal anal examination, and also the deep anal pressure, which again we did in the rectal anal. So using these three components, that is the sensory examination, the light touch, and the pinprick scores, if any of them is 1, then any of them is yes. If the voluntary anal contraction is present, if the deep anal pressure is perceived, or in the S4 and the S5 dermatome, if there is any light touch or pinprick is recorded as 1, then it will be an incomplete spinal cord injury. Else, it is a complete spinal cord injury. It is as clear as that. So in this example, very pretty clear we were. So there was no voluntary anal contraction, and again there was no deep anal pressure, as recorded in the forecheck, and therefore we have recorded it as a complete injury. So that we have finished 4 levels of classification. The next comes how to determine the ASIA impairment scale. The ASIA impairment scale, for most of the cases, is quite easy. For the rest of the cases, if you follow a particular sequence, then it becomes really easier. First, you see whether the injury is complete or incomplete. So for that, we already have seen, we use what is the S4 and S5, dermatomal, the light touch and the pinprick sensation, the voluntary anal contraction, and the deep anal pressure sensation. If any of these is present or absent. So if these are absent, then it is a complete and it is recorded as A. If it is not, then is the next question that needs to be answered is that is the injury motor complete? Because you know that it is sensory incomplete because there is some form of sensation that is preserved. So if it is a motor complete injury, then you will go to the next step. Of if it is no, that is if there is any preservation of voluntary anal contraction, then you'll record it as C or D. You'll go further. However, if only the sensation is present, that there is no voluntary anal contraction, it will be recorded as B. Now, further to this, they have added, now comes the role of non-key muscle. You don't have to test the non-key muscle every time. So, if your patient is greater than as B, then you have to worry about the non-key muscle. So, you have to test Y because B can become C, then there are 2 rules to be followed. One, if the voluntary anal contraction is present, the B becomes C. That is the sensory incomplete injury becomes a motor incomplete injury. If the motor function is present, 3 levels below the motor level, be important that this is not the neurological level you're talking about. You're talking about the motor function more than 3 levels below the motor level on a given site. If it is present, then again the patient will be classified as C or D. So what are these non-key muscles that are tested? Again, these are all very easily listed in the worksheet, very easy to be followed. These non-key muscles, again, you worry about them only when you are dealing with AIS B classification, and you have to be sure that it is C or D. So specifically for C. So you need to know whether some function is preserved at 3 levels, more than 3 levels below the motor level of that particular site. Again, it is not used for zone of partial preservation. It has no role in motor level. Even though I have used this, that it is not used for zone of partial preservation. Whereas you remember when I mentioned about the non-muscles, when they are not present, we use the dermatome. There we use the dermatome not only for the motor level, but also for the zone of partial preservation. But here the non-key muscle, the only role is whether B can change to C. It has no role in zone of partial preservation or in the motor level determination. But there is an exception to this rule when it comes to ZPP, which I'll explain in another slide with an example. That is only one exception to the rule. So what are these non-key muscles? These are very easily listed. You test these are again the same motor levels for which the key muscles we have already seen during the motor examination. These are just for the same level. What are the non-key muscles? So for example, at C5, you saw that it is the bicep that we tested. That is the key muscle. So what are the non-key muscles? Any other shoulder. So if you look at here, what is the difference? Here, it is not an individual muscle that is tested. It is basically a movement that is tested. You don't test a particular muscle, but your shoulder movement, flexion, extension, abduction, adduction. That is one point. And another point is you do not grade them. It is not necessary to grade them. You just mention in the comments box whether this non-key muscle function is present or absent. That is all. So now, going back to the algorithm, you have checked whether it is complete or incomplete. And if it is incomplete, you are again checking whether the person can meet to C by looking at the voluntary anal contraction and motor level. Any preservation of motor level, if the motor level is preserved in key muscle itself, then there is no problem. You use the key muscle and you mentioned that motor level more than 3 levels is present. But in places where there are no key muscles, we should to test also the non-key muscles 3 levels below the motor level on each side, on the right and the left side, to determine whether the person can move from B to C during the time of exam. And if again between C and D, very simple. Here the neurological level of injury is important. If at least half of the key muscles, now we are worried only about the key muscles. Once you have come to C, to classify them as D, you have to see what is the functionality or what is the viability of the key muscles only. At least half of these key muscles below the particular neurological level of injury should have a grade of 3 or more. So in such a situation, automatically we will classify them as B or C. And finally, when complete recovery has occurred, we will classify it as C. So I hope it has been clear till here. And we will move to this example to find out what will be the classification for this patient will be. So this is a very simple case. So we know that this person had no deep anal pressure and he had no voluntary anal contraction. At the S4, S5 dermatome, there is 0 is marked for the light touch and the pinprick for both the right side and the left side. So it's a very direct process. This is a case of AAS, that is Asia Impairment Scale Grade A. Now we will look at a little tougher example, an example where I have used the non-key muscle. So this is a case of spinal cord injury. You look at here very carefully, the sensory dermatomal of the light touch on the pinprick on the right side is marked as 2 till D2. Okay. After that, it is 0 till the end, including the S4 and 5 segment on the right side. On the left side, light touch on pinprick is marked as 2, but it is normal again till D2, same as for the right side. But somehow there is some preservation of the S4-5 segment which is has been as per this example that has been quoted for the purpose of learning. So let us assume that this is 1, and also he has some deep anal pressure, but he has no voluntary anal. So taking this example, what would be the neurological level of injury? What would be first the sensory level of injury? The motor level, again, till the C5 till T1, all the key muscles, it is normal. After that, the next key muscle is L2, which could not be recorded is 0. But there is some preservation, there is complete preservation of the dermatome T2 on both the sides. And it remains the same. The motor examination is the same for both the sides. But in the comments box, it has been written the right adductor muscle strength is present. So what is the right adductor muscle strength? That is the hip muscle. So that could be, that is the non-key muscle of the L2 segment. So the L2 muscle, non-key muscle function is preserved. So we do not know here what is the power of this muscle. We just have recorded that the function, that is adduction function, there is some movement that is present. So what would be the sensory level? There is, I think, no doubts in that. That will be D2. The motor level, again, as we have seen before, there is no confusion in that, D2. Whether it is next is the what could be the neurological level of injury? No confusion regarding that. Again, it is D2 because that is the most rostral with normal preservation of the dermatome, the myotome, for both the right and the left side. The next comes what is we have seen whether it is complete or incomplete injury. So we saw here on the left side there is some partial preservation of sensation with the light touch in the pinprick, and also the deep anal pressure is present. So therefore, this is an incomplete injury. The question is, what will be the impairment scale grading? That is the Asia impairment scale grading. Whether it is going to be B because it is an incomplete injury, or whether it is going to be C. So here we use that in the algorithm that I mentioned. Whenever you are dealing with B, be very careful. You have to see whether the voluntary anal contraction is present. Well, it is absent in this case, therefore it is not C. But there is a second rule. You have to look at what if there is any preservation of motor function at more than 3 level below the neurology of below the motor level of that particular site. So below D2, is there any key muscle that is present? No. But there is a non-key muscle function that is present, and it is at L2. And therefore, we will record this as AISC. So it is as simple as that. We use the non-key muscle only for this purpose. And remember, I mentioned about the zone of partial preservation. The zone of partial preservation recording is important because if some partial preservation of function is preserved, then the potential for neurological recovery is very high. And hence, we record the dermatomes and the myotomes caudal to the sensory on the motor level that remain partially elevated. And again, it is to be used only in injuries with absent motor or sensory function. So whenever there is some, even in incomplete injury, I'll come with that example so that it becomes a little clearer. So if there is some voluntary anal contraction, if there is voluntary anal contraction is present, or if there is sensation that is deep anal pressure is present, or the light touch is present, or the pinprick is present, S4 and S5, we record the ZPP as not applicable. Only when it is absent, the motor ZPP is to be recorded when there is absent voluntary anal contraction, and the sensory ZPP is to be recorded when there is no anal pressure, or the anal pressure is not received, deep anal pressure is not received, or the S4, S5 dermatome, the light touch and pinprick sensation is not received. So coming to that same example, as I quoted before, that is that the person with right adductor muscle strength being present. So we recorded it him as C because more than 3 level he was having function. Now, what would be the sensory ZPP of this patient? You record that as not applicable for both the right and the left. And why? Look at this example. At this example, whenever you record the deep anal pressure as being perceived, then immediately ZPP is not applicable for both the right and the left. Whereas when suppose the deep panel pressure had been low in this case, and you had only S45 recorded as 1 and 1 on the left hand side in this case, then the ZPP for the left would have been S5 and not as not. It would have been only for the left side, it would have been not applicable. Whereas for the right side, if some sensation impairment had been recorded, for example, at T3, 4, let's say, then that could have been recorded here as T3, 4, etc. So in this case, since the deep panel pressure was perceived by the patient, you have to record the ZPP as not applicable. The next comes the next confusing aspect, that is the recording the motor ZPP. As I mentioned before, the most crucial motor ZPP, we use only the follow the dermatomal pattern. We never use the non-key muscles. But there is a single exception to the rule. The single exception to the rule is like in this example, when the non-key muscle changes the grading of Asia impairment scale from B to C. When the non-key muscle function, the preservation, changes the Asia impairment scale grading from B to C, then such non-key muscle has to be documented as zone of partial preservation. So in this case, even though we do not have the dermatomal as 1 here and 2, 3, 4, 5, 6, we use the non-key muscle, even though when key muscle is absent, or even when the dermatomal is absent, we use the non-key muscle. The only reason being because this key muscle, non-key muscle, changed the impairment scale grading from B to C. So that completes our classification. So I hope it has been clear till here, as simple as possible. And how to use these values to prognosticate. We will just rush through the most key aspects of this. Again, these values are useful to prognosticate only if you are measuring, you have the baseline value at 1 month, for example, or less than 1 month, from 3 days to 1 month, let's say. Then only we can predict what will be the improvement at the end of 1 year in terms of any conversion, that is AS conversion from B to C, C to D, whether we are able to predict, if you are able to predict how much is the percentage, those things, whether motor recovery you are able to predict, whether sensor recovery you are able to predict. Apart from the key prognostic indicators of the assessments, that is the motor values or the motor scores, there are key determinants of recovery which you must understand. These include the completeness of the injury, the severity of the injury, that is the Asia scale grading, C as the maximum recovery and not the D. So this is important to know that C has maximum recovery and not the D. It is not because it is because of the fallacy of the impairment scale, that there is the Asia impairment scale. Because of the ceiling effect of the scale, you are not able to perceive. The scale is not sensitive enough to change from D to D. So many changes are lost here. Probably further improvements and revisions of the scale will help us to solve this issue. But as such, based on the severity of injury, if a person more likelihood of converting from C to D rather than from D to E. So that is all you need to remember here. So older the age, the lesser the chances of recovery. There is no clear-cut cutoff for this value. There are some studies say that the cutoff value is 50 years. There are some which say that it is at 65 years. And early surgery, again, a conflicting opinion. There are some new evidences building up, especially for cervical spinal cord injury, that if the surgery is done within the first 24 hours, within the first 48 hours, as per the indication that is there, then the chances of recovery is higher. Again, the evidence still not concrete, but more and more data is pouring in. And in the case of penetrating injury, again, the chance of recovery are very less. So these are the key determinants. The motor recovery, there is nothing new here. It has been as before. The majority of the recovery, most of the recovery happens in the first 3 months, and majority continues for 6 to 9 months and it plateaus by around 12 to 18 months. And when it comes to conversion, looking at the complete tetraplegics, they have a better chance of conversion. 30% of ASA tetraplegics can convert. Some improvement occurs. In fact, half of them improving to D and another half improving to C and D. This is a much higher rate when compared with complete paraplegics. So complete tetraplegics have a better chance of recovery, that is better chance of moving from A to B or C or D than a complete paraplegic B moving from A to B, C or D. Again, the chances of motor recovery in the case of a complete injury, there is very minimal recovery. That is mostly in such cases, it is non-functional. 80% may recover some one motor level. But however, there are some good prognostic indicators, again, as I mentioned before, why there is an importance of mentioning the ZPP. The zone of partial preservation, if it is present, indicates better chances of recovery. And any baseline motor muscle function, if it has a grade 1 and 2, then it has a better chance of having a functional recovery. So that is also important. So the good prognostic indicators are initial strength and whether there are any motor zone of partial preservation. The sensory recovery is, however, unpredictable in the case of tetraplegics. And in paraplegics, as I mentioned before, the chances of recovery are lesser, that is partially lesser, 15 to 20%, whereas in tetraplegic was 20 to 30%. And the chances are more at the lumbar level when compared to the higher thoracic levels. Again, any sensory recovery is very minimal or negligible. And when it comes to incomplete injuries, what is the most important factor that we have to remember is that the modality and the extent of sacral sparing has a great bearing on the prognostication when it comes here. Whereas we saw there, it was the level of injury, whether it was high thoracic, low thoracic, whether it was the lumbar level. And we saw what was the initial muscle strength that is having more important, whether the person will have some recovery in complete injuries. But in incomplete injuries, and that is why any amount of sacral sparing that is present, the extent and modality, that is, if both the voluntary annual contraction and the sensations are partially present, then the chance of recovery is much higher. But if only the voluntary annual contraction is preserved and there is no sensory modality preservation, then the chances of recovery are fairly lesser. That is why sacral sparing. That is why we have to do the rectal examination properly and score that. And we also use this to predict the ambulation, even though several models have been built. For example, this is one model, Van Mildendorf model or the Hicks model, wherein we use the age, the baseline function, motor function of L3 and S1, and the light touch scale. They use this and they predict the model, but mostly they are not foolproof. The only thing that we know is that the level of injury, the severity of injury, the extent of preserved motor function, and the age of the individual, they have a prediction on the ability to recover of ambulation, but there are no clear-cut models still available to predict the recovery of ambulation. Then what is the role of MRI to predict the recovery patterns? So MRI probably could be useful in a, for example, a comatose patient when you are seeing in the acute spinal cord acute time, because you're not able to carry the assessment properly because of cognitive issues, then probably the role of MRI comes in to predict the neurological recovery. However, again, it has not been validated, but there are some scorings. This is such scoring system, the Brain and Spinal Injury Center classification, depending upon the extent of injury. That is whether only the gray matter is involved or whether the injury is beyond the gray matter to involve part of the white matter, or whether there is a complete involvement of the gray matter and the white matter, and whether there is some hemorrhage that has occurred. So starting from 0 to 4 to the worsening, there are less chances of recovery. But again, the international standards have a better prognostication values than the MRI as per the current evidences that are happening. So to summarize, so you have to learn the basics, the complete examination, the systematic guides are widely available, the training modules are available. You can use it to train yourself to reduce the errors. You can use the American Spinal Injury Association training modules, the INSTEP module, in order to learn more about this classification. And there are some interesting articles also available on tough cases of how to classify the tough cases. You go through them so that you train yourself and do it again, whenever you have the chance to do again. most important is a clinical judgment. Don't depend completely on online algorithms. And the purpose of this is to prognosticate. So try to remember the key determinants. What are the key determinants? Whether it is a complete injury, incomplete injury, the severity of the injury, and the other important prognostic indicators, like whether there is some sacral sparing that is present, that is incomplete injuries, as in order to be able to tell the prognostication of the patients in an ethical manner and in a proper principle manner. So what I have not covered in this is the optional assessment, which is important, which are part of the comprehensive neurological examination. And what I have not covered in this, we have to read further, is the adjunct to the international standards of neurological classification, the autonomic function, wherein you assess the cardiac function, the blood pressure, the heart rate, the bowel and function, bladder function, the sexual function, the respiratory function, and also the temperature and the sweating. All these are recorded in the autonomic function chart. And that is an adjunct to this, but it is not currently recommended because it has not much value on predicting prognostication or on planning management, etc., because that is done in a different manner altogether. And another thing that I have not covered here is what is known as an expedited version of international standards classification that was launched in 2020. The expedited version was basically to speed up the process because, as I mentioned, this is a tedious process, but there are some situations, not always, some situations, like if you see a patient in acute spinal unit and you have to assess this patient immediately to take him into a study. So immediately you have to assess within that 5 to 10 minutes what is the level of injury and what is the severity of injury. You do the expedited version. The expedited version uses the same worksheet as the normal version, but the algorithm, that is the step by step, the steps are reduced. You not go top to bottom, all the steps. You can skip some of those steps so that you arrive at the injury severity classification a little quickly. And with this, I conclude my presentation. Thank you. Thank you, Dr. Sahu.
Thank you, Dr. Srikumar. Wonderful presentation on SCI impairment scale and prognostication of spinal cord injury. Really interesting talk, and rather is talk which is required for all physiatrists, all PG students must know. Even we do also, we commit some mistakes, and say really you said that repeated practice can make the person perfect for assessing this. So we will expect some questions from the participants. In the meantime, I have only a few, 1 or 2 questions from my side. Okay, so this assessment of sensation, this is mostly a subjective assessment.
Yeah,
so we have to rely on the opinion or the bias of the patient, that whether he is having the sensation is grade 2 or grade 1 or grade 0 depends upon the opinion of the patient.
Yep.
So sometimes the sensation might be normal, but they say it is impaired because of subjective feeling. Even it is may not, one side it will be 2, other side it will be 1. So how do you avoid these errors? Because solely by depending the level depends upon this assessment.
Exactly. So you can use a clinical judgment and you repeat it a number of times. That is the only option you have. And you compare it with the normal, hopefully if the facial sensation is preserved, you compare it with the normal face sensation and you try to reduce the error. Other than those, you do not have any other options. You have to rely completely on the response of the patient.
The second thing, where the patient presenting at late stage, say that after 2 months or 3 months, when the spasticity is already established, or the people they have some of the contractures rolling, there also motor assessment is problematic. It's difficult to say whether the power is grade 3 plus or not. Yep. There also confusion arises whether what is the level now, motor level, what is 3, because patient cannot complete the full range of spasticity. So how do you decide in that situation?
You assess even in the presence of spasticity, you grade what is the motor power because it has a functional value. For the presence of contracture, you have to grade whether at least 50% of the range of motion has to be present. And at least if 50% is present, then we assess the motor power and use that as a reliable indicator of the preserved motor function. If it is more, then the findings are not reliable. For spasticity, we consider with the spasticity what is the motor level, what is the motor function that is present.
I mean, the power reduction
at different aspects of the day. You can, if you have, like, for example, the spasticity, is a variable phenomenon. It can vary during the time of the day, depending upon whether the person has taken the antispastic medications or not, whether you have before the assessment or he has skipped the medication. So those factors you have to take into consideration. And you can introduce a standardized protocol as per each case, say that we have to do the assessment for this patient everyday basis at this time, provided he has no fever, no other urinary tract infection, any other factors or pressure injuries that can worsen the spasticity. So those kind of factors have to be taken into consideration. But otherwise, you go and record whatever is actually present and taking into the limitations that are there.
Okay, and third is that in case of a spinal shock, you never know what time the spinal shock is completely went off. Then how do you decide that, yes, now I'll go for the motor power assessment? You're not sure that the spinal cord is completely gone.
You
spinal
should
shock
not
is
worry about the effect of spinal shock on motor power assessment. If the spinal shock is there, it is there, or it is not there. And you record the motor power irrespective of that. You record the recovery of spinal shock by using whether the sacral reflexes are coming back, which can be done using the bulbocavernous reflex or the clitorocavernous reflex, or the cold water assessment of the neural the bladder function in order to see whether the recovery has come. So that has whether the spinal shock has come back or not, that is not part of the again the classification. You record the motor power baseline.
Okay, so we'll take up some questions in the chat box.
Yeah.
One question, so if sacral sensation is impaired due to non-spinal injury cause, how to classify a patient in this condition?
Yeah, again, as per the definition, if you have to mention, and again, you have to assess whether this impairment is to be considered as normal or not normal, depending upon case by case. If there is no hard and fast rule here. For example, not the sacral sensation. Let's say, for example, a person has a common peroneal nerve injury, and suppose he has an L2 level motor level, that is the hip flexion, L2 level is preserved, and that is recorded as the grade 3, let's say, and anything above is also normal dermatologically. And then you record the L3, that is the knee extension, is you record it as L1, and then you next what you see is that L4. So L4 is ankle dorsiflexion, but this patient has also has neuropathy, let's say, a common peroneal neuropathy. So this is a very tricky situation. He has grade 3 or grade 3 at L2, and at L3 is having grade 1, and therefore at L4 it could either be grade 1 or it could be also grade 0. And this person has grade 0 either because of the neuropathy or because of the spinal cord injury. We do not know. So you have to use your clinical judgment on a case-by-case basis. There is no clear rule to be followed. You have to just mark it as aspects, define in the comment box, as per your clinical judgment, what is this non-clinical condition, and whether this non-clinical condition, for the purpose of classification, you are going to consider him as normal or abnormal. That is it. It is your judgment. There is no rule for it.
Another thing was that there is an assessment of 2-point discrimination. What is it is less than 10 millimeters and more than 10 millimeters. It has it in relation with the prognostic value?
No, so 2-point discrimination and all those things are not used for the prognostication. There have been some studies which have quoted some improvement using that, but as for the standardized assessment, it is not used. We use only the pinprick and the keep it as simple as that.
Okay. So far, there are no questions in the chat box. Thank you, Dr. Srikumar. Really wonderful presentation. Actually, I was expecting many questions today. I thought that the discussion will go for more than half an hour besides your presentation. Anyway, the presentation will be very well available on the YouTube. And all the participants, if there is any doubt and they are hesitating to ask in this forum, please go through the presentation. It will be uploaded very soon in the YouTube. You can go again and again through the presentation. You can clear your doubts. But I want that the presentation or the discussion should be more interactive. We are expecting more questions from the participant side. However, there are no questions. Again, I would really thanks to Dr. Srikumar. In between, sir, any comments from the using, sir? Please here, sir.
I only say that I always am mesmerized with the expertise Dr. Srikumar gives, the fineness he tries to imbibe into the students. I highly appreciate his efforts. Thank you so much.
Thank you so much.
Thank you, sir. Thank you so much, sir. So if there are no questions, then we'll wind up our session. Before wind up, I must thank all the participants, especially Dr. Using sir, for joining this webinar, encouraging every times by joining this webinar. And I must thank all the office bearers of IAPMR for supporting us for organizing this type of webinar. I must thank the PR team also for publicizing this and uploading the webinar in the YouTube. And last but not the least, I must thank all participants who have joined this webinar and make it a grand success. Thank you. Thank you very much. Thank you, everybody. Good night.
Thank you, Dr. Sahu. Thank you.